Hi everyone, Professor Peter Nash here, School of Medicine, Griffith University in beautiful downtown Brisbane, reporting for Room Now, ACR Convergence in San Diego. We're going to talk about a couple of abstracts, 0514 and 0538, which are looking at difficult to treat axial spondyloarthropathy. We'll talk later about difficult to treat psoriatic arthritis, and you know there's been a strong movement to define difficult to treat RA, so this is following along those lines. The first abstract comes from a French group, and they're trying to define difficult to treat axSpA, and they looked at a large French database and they found 23,000 axSpA patients, of which about a half had taken a biologic or a targeted synthetic DMARD. Now they followed those patients and they defined difficult to treat as having failed 3 biologic or targeted synthetic DMARDs, or failing 2 that were of a different mechanism of action. So when they looked through this massive database to see which patients fitted that definition that they came up with, and you can argue whether it's reasonable or not reasonable, they found almost 10% across the board would be classified as a difficult to treat axSpA, and they found if they looked in the patients who had already failed a biologic or a targeted synthetic, you're talking about 20% of that population, 1 in 5 considered difficult to treat. So what were the factors that were predictors of being difficult to treat? Female gender, peripheral arthritis and peripheral symptoms, the presence of psoriasis, and then things like depression, hypertension and smokers when you compared not difficult to treat with difficult to treat. Now this database has nothing about disease activity in it, which is one of its biggest limitations of this particular study. So the bottom line is, according to this definition, difficult to treat axSpA is really quite common, and the question is, what is the implication? What are we going to do about it? And so we turn to the next abstract, which is 0538, which is a Spanish cohort of real-world patients, 101 of them, who were about to start a biologic DMARD for axSpA, and these people had already failed a couple of biologics or targeted synthetics, and their definition of a good response was staying on the same drug for 3 years. And they found 42% of their patients had difficult to treat axSpA, and the predictive factors, B27 negative, smokers again, relatively short symptom duration, having IBD or other comorbidities, or enthesitis, and they found that a 6-month time point was a very good point to predict outcome, who was going to do well and who was going to be difficult. So what does all this mean? What are we going to do about these patients who are difficult to treat? We better stop them smoking, we better treat the peripheral comorbidities, and we better pay attention to the enthesitis, to the depression, the hypertension, etc. But really, if we can identify this group early, are they a group that needs more aggressive therapy at the beginning? Do they need combinations? And then you can simplify the regime with maintenance. So if you can identify the bad prognostic group early, maybe we'll treat them more aggressively, maybe we'll treat them differently, but at least we can work on these peripheral factors and do something about them, identify the difficult to treat early, like at month 6, and do something about limiting their difficulties over time. So that's all from now, and thank you for your attention.